there are many international courses as well. And this is the one time which we thought of starting for our own Indian diploma in critical care medicine, IDCCM training. We should be doing something that they're lacking for so long. That's why the idea, the concept has started or germinated. So with this background, I would not take further time. We know as a team what it takes to get success. And that's why we have devised this plan for the first time, that there should be one mock test before you jump into all the nitty-gritties of preparation. And then we would be discussing how you should be approaching each question with the idea, with the concept. And for that, we have taken almost 15 days, I would say, Dr. Sananta, then Dr. Alisa, and the whole team has given, I would say, enough efforts to select the questions with the answers. And you can see in the debrief session how that has been meticulously developed. With this background, I would request and hand over to Dr. Alisa for the further proceedings. Thank you, all of you.
Thank you, Tapas sir. So it was a great introduction by sir. So I'm Dr. Alisha. I'm presently working as a consultant in critical care medicine in some Ultimate Medicare Bhubaneswar. I'm basically MD pulmonary medicine, and then I've done my IDCCM from Apollo Hospitals, Chennai. So because my background itself speaks, right? Pulmonary medicine and then IDCCM. So I know how tough an IDCCM preparation and studying will be. Because at the exam, you are expected to know something which a DRNB person also, okay, maybe not the research part and the article slot in detail, but the management, how you manage or a DRNB candidate is going to manage is no different. And for that, you need to be well versed in your subject. So 1 year of working, in that you should be reading, you should be working, and then you should be ready for the exam again for, theory and practicals. So I also did my EDIC. I cleared my EDIC recently, and I had joined the TRICS course. And after seeing the TRICS EDIC, we thought, why not have something for IDCCM, right? Luckily, initially, I had a group of people when I was preparing. We were a group of 5 to 6 people. So it is such a tough exam in the sense that there is so much to read and so less time to read also. So that's why group study is important, and that is actually based on this only the concept of TRICS-IDCCM course started. So as we know, exams are coming. I think roughly around March 2nd or 3rd week, you will be having your exams. Mostly March 3rd week, it was 9th is anyway Shivratri. On a Friday, you will be going and giving your exams. So the exam pattern, as we know, is a multiple choice questions, and you have to select the single best answer. The very good thing about IDCCM exam is there is no negative marking. So that's a really nice thing about IDCCM I like. So you can attempt all the questions. And the passing cutoff varies because ideally is always your topper's marks, which will be considered for your passing cutoff, right? And if you look at the pattern, if you look at the intensity, or you tell the tough part of the exam, it can vary from your March batch to even your July batch, right? So the exam, actually, the concept has kept changing over the years. Initially, when my seniors gave exam before 2020, it was more of fact-based. Then for my batch, it was the first online IDCCM exam 2020 because of COVID. It changed to a lot of case-based questions. And now again, they have come back with a mix of case-based and fact-based questions, in which they are trying to even, in this fact-based questions, they are trying to go into deeper into questions like, mechanisms, lot of pharmaceutical properties of drugs. So the exam pattern keeps evolving, changing. If I can say it correctly, they're actually almost getting at par with the EDIC level exam right now. That's why if you see, our theory and practicals are almost same like the EDIC pattern, right? So you ace this exam, then you will be ready for practicals. So only if you clear the theory, you are ready for your practicals, right? So what are the materials? There'll be a lot of standard textbooks available like Washington, Oz, Fink, there's even Irwin Rippe. So there are a lot of books available. Somebody may tell you that reading Washington, I cleared the exam. Somebody is going to tell you I read Oz and I cleared. Paul Marino, a lot of people tell, but I feel Paul Marino is not frequently updated. So these are the different standard textbooks available. But is it enough? No, because we felt that during our preparation also, this was not enough. That these books are very good for revision, but you need more clearer concepts. So how do you clear your concepts? Sometimes you may need to refer medicine books, right? Because most of your critical care medicine, the physiology part, you will require some reference to medicine books. Even sometimes your anesthesia books, especially for your hemodynamic monitoring, you will have to refer to core standard textbooks. All this is possible if you're reading in a group or you are discussing in constant discussion with your peers, and then you get a better idea about how to approach the exam. Also, apart from all this, you will require latest guidelines. Some books may have been updated 4-5 years back, but after that, if there are recent guidelines, then the management would have changed. So you will have to answer according to the recent guidelines. And review articles, because review articles, I feel, are the best in a way. They would have given a concise summary of the topic in a whole, also citing the important research or important evidence. So all this would be required for your preparation. You cannot just depend on your book. Maybe if only reading Washington by fluke, you may pass, but that's too risky, I feel. You always should be well read, because it's not necessary in an exam. You will know all the options sometimes to an answer. I mean, sometimes to a question. But at that point of time, if your concepts are clear, and if you can at least rule out 3 based on your idea of the physiology and concepts, you can reach a fourth answer. You can reach the final answer. So a thorough knowledge is important to approach all these IDCCM questions. We cannot just do 50-50 and, tick the best option and do, right? We have to score well, not just the passing mark. So what is important? Discussion among colleagues, sincere attendance in rounds. Why? Because the syllabus is vast. So there, because as much as you read, there is a chance that you may not be able to cover. You will always feel that, because critical care medicine is vast, right? You're almost dealing with every system of the body, the emergencies of those systems. So covering all of this is going to be difficult. So can we help you with something? Like as Tapas sir told, teamwork makes the dream. That's why this TRICS-IDCCM course, which we have started. So if you look carefully, this is the course we have designed. These are all our faculties. We are a total of 13 faculties. Most of us, if you go through our names, may not be great stalwarts of critical care, but we share a common vision that all of us have our common interest for love for academics. Most of us are IDCCM pass outs. Actually, most of them are my batchmates or seniors from Apollo Hospital, Chennai. Few of them, I mean, sir mentioned, one of them is also in New Zealand. She's a post-cardiothoracic critical care fellow from NHS Singapore, and we have 2-3 DRNB people also to give their perspective regarding the preparation and the materials. So how have we designed the course? So it is like every Sunday night, you will be getting the reading materials for the upcoming week. Okay. So we have already finished with our toxicology module on the 16th and 17th. So presently it's the gastro week going on. So on 17th night, the students are going to receive they have received actually the materials for the gastro module, all the articles which we have taken time and, the effort and personally collected after discussion among all the faculties. From 17th to 22nd, you are going to read your standard textbooks and the articles we have provided, solve MCQ books, whichever you have related to gastro. And then on 23rd, that is a Saturday, from morning 8 till 24th Sunday, till afternoon 2 o'clock, the link will be active for your exam, right? And on Sunday evening, that is on 24th evening, around 4 o'clock, you will receive a pre-recorded video of the debrief video of the gastro exam, along with the module articles for the upcoming week. That is again cardiology. Why a pre-recorded debrief video? Because we felt it's going to be important for you in the sense that you can keep referring back to it every time you want to revise, and this will go a long way for your revision later on. Okay. The other point we have made sure so that it doesn't become monotonous, right? It is just like reading from a computer, how different it is going to be. So at the end of every month, we have put one live session. If you look at toxicology, gastro and cardio, then you see there's a live session where all of the faculties are going to come live on that day, maybe for an hour. And we take feedback from you. Any extra topics do you want to be covered? Do you want any PPTs to be shared? Any articles? Do you want us to teach any particular literature or lecture topic? we feel it's going to be very boring if we just keep on giving lectures to you, right? Rather than that, we thought how to make you approach this preparation for the IDCCM exam in a question based, so that your fear for MCQs are lost. I'm sure after postgraduate, until unless you have enrolled into a course for IDCCM, you didn't have to write an MCQ exam, but your exit exam is an MCQ. So that's why the fear for MCQs has to go away. So toxicology, like we had 25 MCQs. For the upcoming gastro, we have put now 40 MCQs. So the debrief video will be the faculty, suppose like Dr. Vinya and Dr. Aditi will be taking the debrief video. It will be a pre-recorded video. So those 40 questions, they're going to discuss with you in detail, give you enough references about how to approach those questions, and, help you in shortlisting your answer, and also give you some overview about the important topics which should be covered in gastro. Okay, so this is how all the modules have been planned, and at the end of every month, as I said, we have live sessions. We are trying to cover all our modules by at least 25th of February. That will be the last with endocrine and miscellaneous, so that 25th February onwards till your exam date, you have enough time to revise, because revision is important. How much ever you read, I feel revision is important. And we also have planned 2 mock exams. These will be 100 questions in 3 hours, so that you get again a real exam experience, which will be timed, and then you are all ready for your exam. So this is like a short overview of our pattern. Also, I would suggest when you're preparing for IDCCM, whatever articles you read, keep them, grouped in one folder under one, in your tab or your laptop, whichever you use, in a folder, so that during revision, it will be easy for you. Apart from your standard textbook, always write down how you are going to revise every single system and from where. All that should be written down properly in a notebook, so that your revision is smooth and easy. So we already have 25 candidates enrolled for our course. And as I said, we have finished our toxicology. We are heading to gastro. There's still time. We would love to have you all in this course, and we hope we can help you out. As sir told, we have a small study group where the candidates post questions for us, where we post questions for them. They keep asking doubts, or we keep posting certain important pointers, which are going to also, we try to motivate them, so that it's going to help them in the long run for the IDCCM exam. Without taking much time, I'm sure all of you will be very eager to hear to Dr. Sanand sir regarding the debrief video. So I'll hand over to Sanand sir. Thank you.
Thank you. Thank you, Dr. Alisa, for briefing about the course module as well as the structure of our program. And with this, I also right now not taking much time, but I would like, before handing over to Dr. Sananta, how were the questions from the candidates? They can post in the chat box. What was their experience? If 1 or 2 people, or 5 people can just share their experience. How did they feel about this mock test?
They can take 2-3 minutes, because I'm trying to give them the response also, why they are, how was the response, so that I can show which question was attempted how many % time.
Yeah. So 2 minutes break as suggested by Dr. Sananta
So
before.
that I can, because I'm
So
just
you
copy
can
pasting their
post.
responses into the presentation.
Yeah. So you can post in the chat box if you like the idea of this type of mock test. If you encourage us, then maybe we can have 10 to 15 questions every month basis till your exam, like 2-3 sessions of mock test, where we can cover up 10 to questions, 15 questions and discuss. We have anyway plan of one live interaction with all of you. So in that, we can take the opportunity to share few questions before the live discussion part, and that would be helpful. It's not that only it would be discussing about some theory part, rather some of the questions also we can share. So anybody who wants to share, they can post in the chat box, and we are now gearing up to start the debrief session. Any of the faculties? Okay, there is a question in the chat box, said more light on EDIC 2. Dr. Akil, I would be sharing with you. You post one message in my WhatsApp, and we will be discussing in detail. Don't worry, we have a foolproof course is coming up, and highly successful, and many of the candidates almost right now this time 90%. That has like no the till now the record. Okay, so Dr. Richa is writing how we can join this course. Dr. Richa, Dr. Alisa has already explained, and our team would be contacting you immediately after this debrief session ends. Don't worry. We have our team which will be like guiding you. Don't worry.
Suppose 1 more minute, I'm just copy pasting the responses so that people can see how the questions
Yes.
are answered
Yes.
and what was the problem in the question, like answering the question. So I'm on the last one. Give me 1 minute.
Yeah. One feedback for all the trainees. It's not about the responses or your knowledge. Try to also utilize your laptop or like the use your like the tab in proper way, because most of the candidates, they try to only answer the questions, but they will be unable to at the end use how to like submit the answers or the click the link, something like that. All these technical errors, there are many instances I get call from my like trainees as well as other trainees also, because I am one of the IDCCM examiner at the national level, that sir, how to like right now connect to the internet. I have attempted all the questions, but at the end somehow it is not showing that I have submitted properly. So these are some of the like unfortunate events that you have tried your best for 3 months, 3.5 months, 4 months, extensive preparation, and finally at the end it's not about the like your knowledge or like your like depth of understanding, rather something, these technical glitches, which would be very disappointing. So for that reason also we try to give you enough like MCQs and also how you are actually answering. So
All
we
right.
request you, if you are joining our course, definitely it would be like attempt the designated time schedule by our like faculties, and try to attempt in a realistic way. Don't always like keep all those like the exam what we are actually giving at the end of week, that we will not give or we will not appear the test, rather would be only attempt or attend the debrief session. No, rather you should be taking these exams frequently so that all these technical glitches will not be a problem at the end. Yeah, thank you. Yeah, so Dr. Sanand, are you ready?
Yes. Thank you, Tapas, for all those advices. So, um, as you were saying, if people don't know me, I'm Sanant Dash. I work as an intensivist in Australia, but trained in most of my life in India. So part of my heart is there still in training and in education in the Indian environment. Now, I'll not take more time in the introduction. Let's see what people have done. So that's the review of the questions that we have done. Um, so we have 15 questions and I've given 4 marks to each just to make the calculation easy and look a little bit more fancier rather than getting 10 out of 15. There's something substantial out of 60. So the median rate or median marks of the 15 questions were 32. So just 50%. People have scored just above 50%. I guess that is the pass mark, isn't it, Tapas?
Yes, 50%. But I
So
would say, Dr. Sanand,
yeah,
now ITCCM passing mark, the benchmark is going up.
yeah,
So targeting 50% would not be the idea.
yeah,
And we should be targeting at least 70% to be on the
yeah,
safer
yeah.
side.
Yeah, no, I agree. So the median marking was like 32, and you can see the distribution there. I don't have to explain, but there are more people on the left compared to less people on the right. But I mean, um, 32% or 50% out of whatever we have given have crossed the pass mark, but the question standards are slightly difficult, I believe. Just I genuinely kept it a little bit difficult so that let's see how we are up to the challenge. But um, it's a difficult exam. It's not an easy exam. And the problem with this whole training course is you get only 1 year of practical experience before appearing such a difficult exam. So that's why a little bit of coaching, little bit of hand holding is required. And that's why we thought of bringing this course to your consideration. Anyway, so this was the first question. So we have 15 questions. I will try to finish up in an hour or probably hour and 15 minutes. Let's see how we go. So this is the first question. This is a 70-year-old diabetic patient presenting with severe headache persisting for last 4 days, exacerbating by lying flat, accompanied by double vision. This morning, he experienced a seizure, prompting his visit to the hospital. Physical examination revealed a swollen left orbital area with chemosis. There was no reported history of trauma. Additionally, the patient has a 7-day-old infected ulcer in the left side of the upper lip. On eye examination, the left eye displays medial deviation. The patient has a positive history of antiphospholipid antibody syndrome. CT brain with the venogram reveals the following findings. What is your diagnosis and management priority? Very lengthy question. That is the style of the question nowadays because they talk about a clinical or a case vignette. So they want to provide as much as information that can be provided in the question. So the question becomes lengthy. This is again a test of your what do you call the evaluation, how you do, how you rip apart the question, how you get your information from the question, which is such a long text. If you analyze this question, so this is a 70-year-old gentleman with a past 4 days history of headache. Now he has seizure, he has double vision, he has swelling in the left orbital area, he has history of a ulcer in the left upper lip. Then he has on examination you have found that the left eye displays a medial deviation. So there is a cranial nerve palsy with it. And he has a condition which is prothrombotic, which is antiphospholipid antibody syndrome, right? And specifically, they are talking about a venogram. Now, venogram is not usually done. Venogram is done in specific situations such as this one, or someone who is a pregnant patient, right? Where you are thinking of only one pathology, which is a cortical venous thrombosis or cerebral venous thrombosis. So if you are given a question which says about venogram, the first thing that should come into your mind is a cortical venous thrombosis or a cerebral venous thrombosis, right? So that's your diagnosis without looking at even the choices or without thinking more, without looking at the scan. Venogram with that presentation, that means it is a venous sinus thrombosis. The choices were subarachnoid hemorrhage will require a DSA and coiling. So why do you get a subarachnoid why somebody will ask for a venogram for a subarachnoid hemorrhage? Usually not, okay? It will be an angiogram for a subarachnoid hemorrhage or a DSA. Cerebral venous sinus thrombosis will require therapeutic anticoagulation. That's the correct answer. Posterior reversible encephalopathy syndrome will require BP optimization. Now, they talk about BP optimization, but there is no BP given in the question, so that's not the answer probably. We don't know the BP. How will you optimize the BP? Now, spontaneous subdural hemorrhage. Yes, there's a little bit of haziness there, which and there is a line there which may be thinking, oh, it may be a subdural hemorrhage or not. But I mean, with that presentation, it is highly unlikely to be a subdural hemorrhage. Why do you get a venogram in that? So the thing that rings the bell is the venogram. So this is a cortical venous sinus thrombosis. The presentation fits with the eye swelling, with an ulcer in the lip. That is the danger area of the face that goes that can track into the non-valve venous system, into the cavernous sinus, and then going into the brain. So that's again a point to note. So if you have an ulcer in the lip or in the danger area of the face, then that predisposes to cortical venous sinus thrombosis. Similar case can present with a infection in the middle ear. So somebody with a ASOM or a CSOM, suppurative otitis media, can present with similar presentation where your sigmoid sinus or your other sinuses, venous sinuses, may be thrombosed or may be infected and thrombosed. So if the question asks about someone getting a venogram, then it rings the bell. Whether it is a pregnant patient who is having a cortical venous sinus thrombosis, or whether there is a spontaneous like any disorder leading to a venous sinus thrombosis. So that's the answer. Now let's talk about few. So this is the answer sheet that people have given, right? The most sorted answer was cerebral venous sinus thrombosis. So I guess people have got the hang of the question, because if there is a venogram, that's a venous sinus thrombosis. That's good. Now going into a little bit of detail about the cortical venous sinus thrombosis. The usual clinical feature is a headache and patient present with focal neurological deficit, seizure, and encephalopathy. I think Tapas was putting questions on which was the most common cranial nerve involved in meningitis. That was an indirect thing that this question is coming in one of the mock exam. So that's why he was pressing on which nerve is involved and what is this in meningitis or raised intracranial pressure earlier. Now, headache is the first symptoms. 80% cases you will see that exacerbated by lying down or Valsalva. This is not completely diagnostic modality, but if the patient says that he has headache more so while lying down or having Valsalva that increases the headache, then that rings a bell that it is a venous sinus thrombosis. Other associated symptoms can be nausea, vomiting, diplopia, any cranial nerve abnormality, neck pain because of the sigmoid sinus involvement, and ear infection. As I said, there may be coexisting ear infection. Focal neurological deficit. So 60% cases, the most common sinus occluded is the sagittal sinus. Based on that, you can have a particular set of symptoms in these patients, which I don't think are important, but if it is a medical exam or a medicine exam, people are more concerned about which venous sinus thrombosis is occluded, and based on your clinical finding, can you predict it? Unusual to ask those questions in the exam, but few important things to look at is if you can see sigmoid sinus, in that case, you will have pain in the mastoid region, or you'll have a suppurative otitis media, and you'll have cranial nerve palsy, which goes through the sigmoid sinus, is a cranial nerve 6, 7, and 8. So those pulses are common, right? Now, seizure, again, a very important clinical features in that. Usually focal, but may progress from focal to generalized. Encephalopathy, the people may have communicating hydrocephalus because of the occlusion of the venous system, which is the draining channel for the CSF. So patient can have communicating hydrocephalus with thalamic dysfunction such as mutism, amnesia, can have worsening signs of cerebral edema, and also radiological signs of cerebral edema with herniation if remains undetected. Then other cranial nerve palsy, as I talked about. Now, there are few signs in that. So you will have a high D dimer, which is a thrombotic condition. You will have a high D dimer. If you are doing in your setup, then that is a corroborative result that you can think of why the patient has a high D dimer. Specifically important in COVID patients where you have a high D dimer with a cerebral cortical venous sinus thrombosis, and the patient needs to be evaluated for other thrombophilia. There are specific signs on radiology. As I said, you can see there is a cord sign, which is because of the thrombosed vein, cortical veins. You can see a cord sign sometimes, or a dense triangle sign. As you can see in the suppressor delta sinus, we can get a dense triangle sign, and also there is an empty delta sign, which is the again on the coronal view you will have a empty vein there, which is because of the thrombus sitting in the vein. Very rarely seen, but if it is there, that is a diagnostic feature of that. MR is more sensitive in this case, but other investigation, which includes DSA, can be done if you cannot see with the MR or cannot see with the CT venogram. The most important question that you usually ask, how do you treat the patient? They may show you a scan with a little bit of bleeding in there, saying this patient has a cortical venous sinus thrombosis, and how will you treat it? So the treatment of choice is anticoagulation, because if you don't anticoagulate these patients, they will die. So unless it is a critical bleeding, then you look to anticoagulate the patient as soon as possible. All right. Low molecular weight is more effective and safer, found in various trials. If the medical management is not successful, then endovascular thrombolysis or mechanical thrombectomy has been done, but very rarely required, and it is a procedure which has a morbidity associated with that, right? If the patient doesn't improve with therapeutic anticoagulation and there is progressive neurological worsening despite adequate anticoagulation, in that case, these measures needs to be considered. Now, the patient needs to be on long-term anticoagulation because of the thrombosis, which warfarin or a DOAC can be thought of. But warfarin is treatment of choice if the patient has underlying APLA or antiphospholipid antibody syndrome, or the patient has CKD in the background, because that is safer in the CKD. Low molecular weight heparin is the agent of choice if the patient is pregnant or if the patient has a malignancy. So these may be the questions also. If the patient has cancer, what you prefer in terms of therapeutic anticoagulation? Your answer should be low molecular weight heparin. If the patient has antiphospholipid antibody, what is your anticoagulation of choice? It will be warfarin. Okay. Now going to second question. The question asks for which of the following is false about factors regulating intracranial pressure, right? A little bit of physiology question. So Alicia was saying that there are a few questions which are nowadays more conceptual question like physiology and pharmacology. So you need to know a little bit of those general physiological principle, right? So the choices were ICP is governed by the principle of Monro-Kelly doctrine. Rate of CSF production is or remains constant irrespective of the ICP. Rate of CSF absorption increases with increase in ICP, and raised ICP due to raised PaCO2 is due to decrease in cerebral blood flow. So asking about which option is false, it is a very easy question actually. The first one is correct. The CSF production remains constant irrespective of the change in ICP. So the formation of CSF is constant. It doesn't increase or decrease based on the increase in the ICP or delta increase in ICP. But the absorption changes with the ICP. That's the principle of CSF formation and absorption. Raised ICP is due to raised PCO2 is because of increased vasodilatation in the brain, causing increased cerebral blood flow that causes increased CSF production and raised ICP. So it is not decrease, it is increase. So the option D is false. Now going into the description of that. So this was the performance of all the 65 candidates who have appeared the exam or the mock test. So most of them got the correct answer as correct. So D was the correct answer. The ICP is raised in increased PaCO2 because of increase in cerebral blood flow, not decrease. Okay. Now, a little bit of theory around it. You may be asked about Monro-Kelly doctrine or what is the name of the doctrine if it is a straightforward question, but it can be asked about the principle, how it is defined. So basically, brain is a closed box, or the whole cranium is a closed box, and the volume inside the cranium is fixed, which is governed by three major factors: that the mass, that is the brain matter, the blood, that is the cerebral blood flow and blood volume in the brain, and the edema. So these are three things that is there, which governs the major component of the cranium, which is fixed and doesn't which is fixed. What does that mean is, if you have a closed box where the brain lies, if the amount of one of the component increases, then there is a compensatory mechanism which initially kicks in. As you can see, this is the normal, this is the compensated stage, and this is the uncompensated stage. So what happens is, brain matter is almost the same, then the arterial blood volume are almost the same. The variable part is the CSF and the venous part of it, because they are compressible. So if there is a cerebral edema, then CSF and venous component decreases in their volume, and the mass due to the edema or increased mass of the edema, right? It gets compensated to a particular value, but then there is an exponential rise once the pressure increases beyond this point, right? In that case, the compensation is lost, and then the brain starts to suffer. Either it will cone, or it will have further cycle of edema and low perfusion state to the brain. So this is an important graph, so which shows the effect of CSF absorption and production with the ICP, right? If the pressure increases, as you can see, the production is a constant line, it's a straight line, it doesn't change. The ICP CSF production doesn't change, but as the pressure increases, the absorption also starts to increase, so that there is less CSF, which is demonstrated by this one. So as you can see, the CSF volume gradually decreases. That means the absorption becomes more as the pressure increases, right? Again, it goes as linearly with the pressure increase. Now, they can ask about CSF physiology, which is an important thing to know. So CSF physiology, pleural fluid physiology, and SAG, that is the serum ascitic albumin gradient. These are the three important things that they ask in the exam in terms of fluids. So CSF, pleural fluid, and the SAC. In CSF, they can ask you about how the infective CSF looks like: bacterial, viral, tubercular, meningitis, Guillain-Barré, how the CSF changes in Guillain-Barré syndrome. In pleural, the Lights criteria, which is exudative, which is transudative, and as I said, in the peritoneal or ascitic fluid, they will talk about SAC, and to rule out a subacute bacterial subacute bacterial peritonitis. How do you rule out, right? So going into the CSF again, as I said, it is produced from the choroid plexus and it is dependent on usually on a CPP. So more than 70, there is no CSF production doesn't change. But if the CPP falls below 70, then the CSF formation decreases due to the decreased cerebral blood flow. There is no change in CSF production with any change in the delta ICP. If the ICP changes up and down, it is regulated by the CPP. So only when the CPP is below 70, then only the CSF production decreases, but it doesn't change with delta ICP or any change in ICP, because this change in ICP is regulated by the change in CPP. So the CPP remains the same even if the ICP goes up and down within the physiological limit. Okay. Absorption, again, it happens in arachnoid villi 90% and directly into the cerebral venules in 10%. So the arachnoid villi stays in the suprasagittal sinus, or other sinuses. That's where if it is clotted, then your absorption becomes decreased or drops down, and you will not have much of absorption of CSF. There will be more CSF in the brain, causing a raised ICP or hydrocephalus. So there is more common hydrocephalus you can see in cerebral venous sinus thrombosis because of the arachnoid villi which got clotted. Again, determinants of CSF absorption. CSF absorption is constant and at low CSF pressure or ICP, but it increases linearly as the pressure or the ICP increases. Okay. There are lots of other factors that governs the CSF production and absorption, and everything comes to the cerebral blood flow. If the cerebral blood flow increases, your CSF production increases. If the cerebral blood flow decreases, your CSF production decreases. So the cerebral blood flow and the pressure, there is a relationship. As you can see, there are multiple factors: ICP, mean arterial pressure, PaCO2, and PO2. This is the physiological range where if the perfusion pressure of CPP is between 50 to 150, the production remains the same. Because the cerebral blood flow remains the same. But as the parameters increase, like the PCO2, if the PCO2 increases, the cerebral blood flow increases. Similarly, other parameters. Not going into details, but you need to know the physiological factor, how CSF is formed and how CSF is absorbed. The third question was again a little bit of physiology question. So which of the following is true about cerebral edema? So there are different types of cerebral edema. They're asking about what is true about cerebral edema. So vasogenic cerebral edema predominantly affects the gray matter. Cytotoxic cerebral edema predominantly affects the white matter. Vasogenic cerebral edema represents increased permeability with an incompetent blood-brain barrier, and cytotoxic edema usually coexists with an incompetent blood-brain barrier. Now you can see the C and D questions are similar except for the name, like the vasogenic and cytotoxic. So one of them has to be correct or one of them has to be false, right? That's the clue in this question. How do you approach it? So if they are talking about the same thing, one of them has to be true and one of them has to be incorrect. Let's see. This was the performance by the 65 candidates who appeared that, and most of them got the correct answer, right? 63%. Going into detail, a little bit of detail of that. So vasogenic is because of increased permeability of the capillary endothelial cells. There is an incompetent blood-brain barrier. So vasogenic is incompetent blood-brain barrier. So it causes influx of proteins from the intravascular space through the capillary wall into the extracellular space. It affects the white matter. So vasogenic affects the white matter. So V is nearer to W. V, W, right? Vasogenic, white matter, incompetent capillary endothelium or blood-brain barrier. Now, cellular or cytotoxic edema seen in head injury and hypoxia. This is because of the swelling of the glia and neuron and endothelial cells due to the release of toxic factors from the neutrophils and bacteria. Cytotoxic edema affects predominantly the gray matter, right? C and G are closer to each other. So cytotoxic is gray matter. Vasogenic is white matter. So that's how you remember. V and W are close to each other. C and G are close to each other. Now, there is a third type of edema, which is called as the interstitial edema or wetting type of edema, where what happens is with the hydrocephalus, the CSF outflow is obstructed. There is increase in intraventricular pressure. There is movement of sodium and water across the ventricular wall into the paraventricular space. It happens in meningitis, where you will say some wetting of the paraventricular space. That is called as the interstitial edema, which is less clinically pronounced, but vasogenic and cytotoxic are important. Question number 4 was, which of the following is false regarding the management options in vasospasm and DCI or delayed cerebral ischemia associated with subarachnoid hemorrhage? So very important part. Subarachnoid hemorrhage is, I think the probability of getting a question on subarachnoid hemorrhage in the exam is very, very high, because this is one of the major neuro abnormality that you encounter in the ICU. So make sure that you read the article supplied to you or whatever the study material you have. Make sure that this is an important topic to read. Subarachnoid hemorrhage, very high chance that you will get questions on it. Okay, so we are asking about which is false. Okay, so early treatment with oral nimodipine has shown efficacy in prevention of vasospasm. So you need to look at the wording of the questions and answers, right? So it talks about prevention of vasospasm. Okay, delayed cerebral ischemia or DCI, prevention with hemodynamic augmentation therapy is not recommended. Okay, again, prevention is not recommended. Then DCI treatment with hemodynamic augmentation therapies is recommended. Okay. Now, routine use of intravenous magnesium is recommended to treat vasospasm. So that's not recommended. This is a false option. So we don't use routine intravenous magnesium sulfate to treat vasospasm. Doesn't work. Okay. That is not recommended in the guideline. There are two standing guidelines. One is from the Neurocritical Care Society, which has come this year only. And the other one is from the AHA, American Heart Institute or Stroke Guideline, which has again come this year, 23. So very important to look at the recommendation from that guideline. Okay. So in subarachnoid hemorrhage, vasospasm and DCI, so nimodipine, oral nimodipine is shown efficacy in prevention of vasospasm. DCI prevention is not recommended. So you don't push up the blood pressure higher to prevent DCI. Okay, if the patient has established DCI, then yes, you treat with higher blood pressure, aiming at a higher blood pressure, hemodynamic augmentation, but you do not start therapy such as noradrenaline or any inotrope to prevent DCI. So that's not recommended. And routine use of magnesium sulfate is not recommended. Okay, let's see how people have performed. Pretty good actually. 47%. This was a bit of a difficult question because of the wordings in it, but almost half of the people have answered correctly. Okay. I become concerned when the green is shorter than the gray part. So as long as the green is longer than the gray histogram, I'm happy with that. Okay. Now that's the guideline I was talking about, 2023 AHA stroke guideline, and there is a Neurocritical Care Society guideline also that has come up this year. So the recommendation from them, this is a summary of recommendation. So DCI prevention with early oral nimodipine, this is the only 1A evidence there. Okay, this is the only treatment that has 1A evidence. DCI prevention with early oral nimodipine. There is less evidence that is supported with IV nimodipine. They do not support, but if you cannot give orally, you can think of IV nimodipine, but there is less evidence around it. Use of statin, used of endothelin receptor antagonists such as the bosentan or bosentan, higher target of hemoglobin, that is 10 versus 7, IV magnesium, DCI prevention with hemodynamic augmentation, these are not recommended by the guideline, either of the guideline. Both guidelines do not recommend use of statin, use of endothelin receptor antagonist, or use of magnesium, or preventive strategy for DCI by hemodynamic augmentation or a higher hemoglobin. All of them are not recommended. DCI treatment with hemodynamic augmentation, yes. If the patient is established or has shown signs of DCI, then you do hemodynamic augmentation. That is recommended in one of the guidelines. Anti-seizure medication for up to 7 days for those who present with seizure or have high-risk group, such as MCA territory aneurysm, high-grade subarachnoid hemorrhage, if the patient is hydrocephalus or cortical infarct. These are the indication when they should have anti-seizure medication for 7 days. That is recommended. Anti-seizure medication beyond 7 days for those without prior epilepsy who present with seizure, that is not recommended. So we should be stopping at 7 days anti-seizure medication. Unsecured versus secured aneurysm. So if the aneurysm is unsecured, then use of tranexamic acid again is not recommended, and one of the guidelines recommends against it. So there is no use of tranexamic acid. This may be a question, because if they go by guideline, so the guidelines do not recommend use of tranexamic acid in unsecured aneurysm. Early aneurysm repair as early as feasible, probably within 24 hours. This is the current recommendation. All right, going into question number 5. We have a 56-year-old female with poorly controlled type 2 diabetes mellitus with HbA1c level of 11, which is pretty high, presented to the emergency room with worsening pain, swelling, and redness in her right lower limb for 3 days. She has had a high-grade fever, 104, for 2 days, decreased urine output, and breathlessness since this morning. In the ER, her blood sugar is 280. This should be milligram, not millimole, milligram per deciliter. Saturation is 88% on room air, and the blood pressure is 100 by a low diastolic of 40. Respiratory rate is 34. She exhibits upturned mentation but is rousable. What are the management priorities in this patient in a time-bound sequence? Okay, what you do in a time-bound sequence. So that means everything given in the each option is correct, but what you do first, what you do second, what you do third and fourth, that is the question, right? So first, I'll go to straight away to the answer. The answer is first one. So what you do practically, that's the most important thing to look at, okay? If this type of patient comes to me, I will first resuscitate the patient, and I know this is possibly a neck fash that is happening. It needs a surgical review because that's the source control. In medicine, everything you do, resuscitation, source control, okay? Everything else can wait. But because if you don't do the source control, the patient will die, will not improve, okay? So that's why the choice is simultaneous resuscitation and urgent surgical review, then broad spectrum antibiotic after blood culture if possible, hyperbaric oxygen therapy, IV streptococcal toxic shock syndrome. So hyperbaric oxygen not in acute stage, is not shown any benefit in acute stage. You can think of if there is an aerobic organism, if there is an anaerobic organism infection, you can think of it, but it is not an urgency. And if in the initial stage, you know that this is a streptococcus that is causing it, then you can think of a IVIG as a rescue strategy. But the most important thing has to be the simultaneous resuscitation and urgent surgical review. That's the first thing to look at. Now, neck fash is again an important question in the exam. There are a lot of things that can be asked in necrotizing fasciitis, starting from your management strategy, what are the types of things and everything. Interestingly, 70% of people have answered it correctly. So they know what is the importance of surgical review. Very, very happy with that answer, right? Okay, now, what you see or what you can be asked in necrotizing fasciitis is the newest score, that is the L-Renic points, to say that whether the patient has neck fascia or not clinically, okay, without doing a cut down on the skin or on the affected area, you can tell whether the patient has necrotizing fasciitis or not by doing this scoring system. So this has come up recently in the literature, so more and more used. So you can be asked about that. Do you know about a score that looks at probability of necrotizing fasciitis? Not widely used at this moment, but this is the question that can be asked. So they use parameters like C-reactive protein, white cell count, hemoglobin, sodium level, creatinine, and glucose, and they can then give equivalent scoring to them. Now, if the score is less than equal to 5, then the probability of having necrotizing fasciitis is less than 50. So it goes by the number 5 to 50. 70 to 75, and 80 to more than 75. So that's how you score the probability of necrotizing fasciitis. Management, again, there are different types of necrotizing fasciitis based on what type of or which literature you read. The simplest way is to say them polymicrobial and monomicrobial. Polymicrobial can be divided into aerobic or anaerobic, and monomicrobial is a group A streptococci, right? So these are the basic classification of that. Risk factors, they can ask you what are the risk factors, which of the following is not a risk factor for necrotizing fasciitis in that way. So most of the comorbid conditions are risk factors for necrotizing fasciitis. So risk factors, again, important things. There are few risk factors that is asked in the exam. So risk factor for rupture of subarachnoid hemorrhage. So rupture of aneurysm. What are the risk factors of having subarachnoid hemorrhage because of aneurysm? So that includes smoking and other risk factors, having other diseases such as Berry aneurysm and all those things. These are the risk factors that is asked in the exam. Now, the second risk factor that is asked in the exam is the risk factor for necrotizing fasciitis. Then risk factors for invasive fungal infection. Then risk factors for having multi-resistant organisms in ICU. So there are few 5 or 6 specific questions that is asked in the exam. What are the risk factors for that? So you need to make a note of those 5 or 6 questions that is asked about risk factors. Okay. So they also ask about the antibiotic of choice in this case. So it can be initial empiric antibiotic, which is meropenem, vancomycin, and clindamycin. What is the role of clindamycin? So antitoxin effect of clindamycin, particularly if it is a staphylococcal or a streptococcus infection. What are the other possible rescue therapy or experimental therapy? They are IVIG if there is a toxic shock syndrome, associated streptococcal toxic shock syndrome. If you are doubting that, then you can use it. And hyperbaric oxygen is not recommended in the latest guideline because it can delay resuscitation, it can delay surgical debridement. That's why it is not recommended even. Question number 6. So 33-year-old female transferred, intubated and ventilated from another hospital, has an elective laparoscopic hysterectomy with bilateral salpingo-oophorectomy. So something wrong with this patient, isn't it? 33-year-old having a bilateral salpingo-oophorectomy. That doesn't fit. Why such a young woman will have a oophorectomy? But she's having it due to severe schizophrenia and cyclical suicidal ideation linked to her menstrual period. So she was so psychotic during her menstrual period that they decided to do the oophorectomy. Probably that's what it is. The procedure aimed to manage hormonal related suicidal thoughts, which is a treatment mentioned in the literature also. She is a mother of a 10-year-old. During anesthesia induction, she experienced profound hypertension. So usually anesthesia goes with hypotension. This patient has a hypertension, right? There are not many things that can cause hypertension during anesthesia. There are a very fixed number of differentials that we'll talk about that, right? So profound hypertension and tachycardia requiring a laryngeal mask airway for ventilation. Despite intervention, oxygen saturation was low, 75 to 80%, with an elevated EtCO2, which is more than 75. Dantrolene and clonidine stabilized her heart rate and blood pressure. She was tracheally intubated and transferred to ICU. Current medication include flufenazine, tapentadol, lithium for mood disorder, and moxonidine for hypertension. On examination, she is deeply sedated with increased tone and global hyporeflexia. Pupils show episodic contraction and dilatation at 4 millimeter. What is your working diagnosis? So this is a very complicated gamut of presentation given to one, but the answer is pretty easy. So now they want to confuse you with someone who is hypertensive and tachycardic. Okay. At the same time, she is hypoxic. She has received dantrolene. She has received clonidine, and she has in the background so flufenazine and tapentadol, right? She is hypertonic but not hyperreflexic. She is hyporeflexic. That's where the crux of the question is. So how many conditions you know that the patient will have less reflexes with hypertonia? Very, very rare, but this one has. So that is the crux of the question, right? So let's see. Answer is neuroleptic malignant syndrome because the patient has fluphenazine in the background. But let's see the answer. Again, most of the people have told it is a neuroleptic malignant syndrome, which is good. They can make it out. There is subtle differentiating features between, so as I said, anesthesia induction, somebody is hypertensive tachycardic or hyperpyrexic. There are not many conditions. There are 3 or 4 differentials to that. So one is a malignant hyperthermia, second is a neuroleptic malignant syndrome, serotonin syndrome, and malignant catatonia. So these are 3 or 4 syndromes that happens in these circumstances, right? This patient is not a young child who are more prone to have malignant hyperthermia, doesn't have a congenital issue that can precipitate or predispose to malignant hyperthermia. Doesn't it usually says in the question that this patient has this, which is a predisposing condition with us. In this question, the predisposing condition is the fluphenazine with schizophrenia, right? The patient is on some sort of phenothiazine, which is a precipitating factor for neuroleptic malignant syndrome. Okay. Now, this patient is not hyperthermic, which is an essential or important criteria for malignant hyperthermia. That's how we rule out the malignant hyperthermia. Patients with neuroleptic malignant syndrome can have presentation without high temperature. That you need to know. Let's see the differentiation now. Now, for a neuroleptic malignant syndrome, the risk factors are baseline psychotic disorder, use of higher doses, rapid escalation of doses of antipsychotic, and if you do parenteral therapy put through the nasogastric. If you have concomitant use of lithium, which is a psychotropic agent, in that case, the chances of having NMS is also increased. If you use high potency agents such as fluthiazine medication, if you have depot preparation, in that case also your chances of NMS is high. If you have comorbid substance abuse, if there is a drug addict who takes cocaine or who takes LSD type of thing, then in those cases the precipitation of NMS is higher. On the background of previous neurological disease also it becomes higher. Now, dehydration is told as a risk factor for neuroleptic malignant syndrome, but we don't know clearly whether it is a risk or whether it is an effect of neuroleptic malignant syndrome. As I said, the offending agent are multiple. There are any antipsychotic drug can cause it, right? You can see antipsychotic drug list: domperidone, metoclopramide, prochlorperazine, promethazine, droperidol, aripiprazole. Also antiemetic medications such as haloperidol, olanzapine, other antipsychotic. Any antipsychotic can cause it. Basically, they say virtually every antipsychotic agent has been associated with NMS. Oops, sorry. Now the differentiating part. So as I said, there are not many conditions that mimic this presentation: serotonin syndrome, anticholinergic syndrome, neuroleptic malignant syndrome, and malignant hyperthermia, right? In this case, you don't have temperature, so it is probably not a malignant hyperthermia. Now look at the drugs that the patient is on. She is on a tapentadol and she is on some sort of phenothiazine. So tapentadol, yes, it can cause a serotonin syndrome, but at the same time, the patient has a antipsychotic, which is again a precipitant for the neuroleptic malignant syndrome. I want you to focus on this blue table, which is the differentiation between serotonin syndrome and neuroleptic malignant syndrome. Now you can see with NMS, there is bradyreflexia with high tone. So patient is hypertonic, but they have the reflexes diminished, bradyreflexia, slow reflexes, compared to serotonin syndrome, where they have hypertonia and they are hyperreflexic. So this is the differentiating point. If you get a patient who is bradyreflexic with raised tone in the background of having antipsychotic agent, is having symptoms such as high blood pressure, high temperature, and tachycardia, the diagnosis is probably neuroleptic malignant syndrome. If the same patient has a battery of medication, that is serotonergic, such as fluoxetine, quetiapine, then tapentadol or tramadol, all those things the patient is taking, he has hyperreflexia, hypertonic, maybe hyperthermic, hypertensive. In those cases, serotonin syndrome comes into as the first differential diagnosis. So the differentiating point is the bradyreflexia between both, right? Management again, they can ask you. So the first management is discontinue the offending dopamine antagonist. You can give dopamine agonists such as bromocriptine. Stop other potential contributing agents such as lithium, or the patient has anticholinergic therapy or serotonergic agent. Stop all of them. Maintain stability, cardiorespiratory monitoring. The patient may need mechanical ventilation, may need high doses of benzodiazepine, IV fluid therapy. Treat the hyperthermia with cooling blankets, ice pack, gastric lavage, etc. If it is moderate to severe, then give benzodiazepine. Lorazepam is the drug of choice. You can treat the patient with dantrolene also. This is an alternative this is an alternative therapy for malignant neuroleptic malignant syndrome, but usually not used alone. So you have to give some benzodiazepine along with the dantrolene and bromocriptine. Okay. Never used alone as a single line therapy for NMS. Dantrolene is the agent of choice for malignant hyperthermia, but not for neuroleptic malignant syndrome. Again, if the patient has serotonin syndrome, the treatment is completely different, because if you think it is a neuroleptic malignant syndrome and the patient has serotonin syndrome, and you start in that line, like give a dopamine agonist, then the symptoms may worsen. So in that case, cyproheptadine is the drug of choice for serotonin syndrome. Okay, investigation as usual, you need to add a CK myoglobin, make sure that there is no muscle atrophy or muscle degradation because of hyperpyrexia. Question 7. So this is a straightforward question. So 50-year female came to the ED, progressive shortness of breath. She has no previous history of cardiac abnormalities. She is on 100 microgram of thyroxine, so hypothyroid probably. She lived alone with a pet dog. She reports that her dog died 8 days ago, which has made her very sad. Her initial blood results are attached. So her creatinine is high, sodium is normal, potassium is slightly high, BNP is pretty high, 12,000. Troponin is also high. She denied any chest pain. Her ECG showed dynamic STD changes, which were diffuse and not corresponding to a single vessel territory. The cardiologist did an angiography and a ventriculogram, which showed the following. There is no significant coronary artery disease. She required 3 days of non-invasive ventilation and then shifted to the ward. What is the diagnosis based on the information? So dynamic STT changes, which changes very gradually to whatever possible rhythm that can be. So it can show ST elevation, it can show T wave inversion, it can show multiple ECG abnormality, but the diagnostic feature is the ventriculogram and a normal coronary artery. So normal angiogram with a abnormal ventriculogram with apical ballooning is a diagnostic feature for Takotsubo cardiomyopathy. That's the answer. All right, let's see how many. All of them, I think 87.7% people have answered correctly. Okay, now I'm not going in detail about the Takotsubo cardiomyopathy, what is the definition and things like that, but it is more common in female, 9:1 ratio. Particularly, it is precipitated by some sort of psychological trauma or some sort of physical trauma. The risk factors are middle-aged female, hypothyroid patient who has previous history of some sort of cardiomyopathy. They can have recurrent episodes also. They mimic the myocardial infarction, but the distinguishing feature is a normal coronary angiogram in those cases. There is a set of diagnostic criteria, the Mayo Clinic criteria for diagnosis of Takotsubo cardiomyopathy. It says it is a transient reversible akinesis or dyskinesis of left ventricular apical or mid ventricular segment with regional valve motion abnormality extending beyond a single vascular territory. So it has to be global, or at least it doesn't fit into a single vascular territory. Absence of obstructive coronary artery disease in more than 50% cases, but some can have coexisting coronary artery disease, which gets worse on that. New electrocardiographic finding consisting of ST segment elevation or T wave inversion, as I said, and there is absence of trauma, intracranial bleeding, pheochromocytomia, or any coronary artery disease, myocarditis, or hypertrophic cardiomyopathy. Complications, there are multiple has been described in literature. Heart failure, most common, pulmonary edema this patient had. The patient may have very refractory arrhythmias, including VT and VF, because of lack of contractility of the apex can have apical thrombus. As I said, there is a high chance of recurrence, 1.8 to 2% per patient year, and death is 5 to 6%. The patient can have stroke and TIA because of a kinetic segment in the heart or arrhythmias. Clinical features, chest pain, dyspnea, ECG finding as we talked about. Trigger is physical, emotional, both, maybe none. We cannot find a trigger for that. More than half of the patient have acute, former, or chronic neurological psychiatric disorders. So that is again a risk factor. Use of ACE inhibitor in ARB when the patient is more hemodynamically stable has shown improved survival. Beta blockers usually not preferred. No rule in treatment or prevention of further episode. That is, there is a large retrospective analysis of quite a lot of patients in NEJM, which showed that ACE inhibitor are the agent of choice when clinically applicable. That can be a question in the exam also. They can ask what is your agent of choice. Risk factors for complications. So younger patients with physical trigger and acute or neurological or psychiatric disease had an increased incidence of acute complications. So younger patients with psychological issues can have an increased complication. Elderly patients with emotional trigger were at low risk. ACE inhibitors or ARB at discharge have improved survival compared to the beta blocker, as I said. Question 8, again, this is a fundamental question. I guess most of the people should be aware of that. So this is about Glasgow Coma Scale or GCS. So on serial assessment with central painful stimulus, supraorbital reach pressure, a 39-year-old male who has been admitted following an out-of-hospital cardiac arrest. On day 2, the response A is seen. Half of that patient you can see response A. And on day 5, response B is seen. Which of the following statement is true? Let's see. So on day 2, he showed abnormal flexion response with which corresponds to the GCS M3. Okay, and on day 5 he shows normal flexion response which corresponds to GCS M4. So A, with the supraorbital pain, if the patient flexes his arm like that with curled of finger, this is an abnormal flexion response which is M3. If the patient does this type of movement with outgoing hands, then this is a normal flexion response, which is on day 5 here or M4. Okay, that was the question. Most of the people have answered correctly, 46%, almost half, which is encouraging. Need to know in and out of the Glasgow Coma Scale. If you struggle on this, there is no way you can pass the exam. So GCS, you have different components. So best motor response. So M component is important because this is the prognostic categorization of the patient based on M score. Various scores uses GCS as their subscores. I'll talk about that. Then central painful stimulus. This is the normal flexor response. As I said, this is the abnormal flexor response. They can ask you, where do you give central painful stimulus? So central painful supraorbital notch, trapezius pinch. Nowadays, we don't do any sternal rub or sternal pressure. Okay. And peripheral fingertips. That's how you do painful stimulus. Facts about GCS. So eye opening. Assess to pressure and not to painful stimulus may be unnecessary. So you put pressure on the supraorbital ridge, and if the patient is not responding to that, the argument is that how can a painful stimulus then give a response? If the pressure response is not giving any response, there is no point giving a painful stimulus. That's why we have stopped doing the sternal rub. It is only supraorbital pressure that we apply. Advantage and clinical implications of GCS. So it is most widely used. It is reproducible by a well-trained staff, easy to perform with minimal training. It has prognostic value, particularly the motor score. So there are various prognostic algorithm which uses a GCS. So head injury algorithm, GCS of 8 or less is severe head injury. Then algorithm for your scores for subarachnoid hemorrhage, where you take various breakdown of GCS for the scoring and then predicting their outcome. That's based on the motor score. Then you use prognostication after cardiac arrest. So if the patient has M3 or 3 or more M3, then the prognostication pathway is different compared to when the patient has a M score of less than 3 or 2, so equal to or less than 2. So poor prognosis if it is less than 3, and possibly better prognosis if it is more than or equal to 3 on the neuroprognostication part of post-cardiac arrest. As I said, categorization of traumatic brain injury, it is used. It is used to determine the need of EVD. Again, Brain Trauma Foundation guideline. Where do you put a ICP monitor? This may be a question, very important. I think I'm not touching bases on that later on. It can be used to indicate the depth of coma, at which one's airway reflexes are likely to become unreliable. That's your head injury when they need intubation. It is incorporated into multiple scoring systems such as SOFA, WFNS, and Apache score as the benefits of Glasgow Coma Scale. Multiple disadvantages also. The most important is it is unreliable in a middle range where the patient has a GCS of 9 till 12. What do you mean by 9 and what do you mean by 12? How do you differentiate in terms of outcome? There is a bit of a gray area there. There is inter-observer variability. It is inadequate to assess the higher cortical function, inadequate to assess the brainstem reflexes. You cannot assess the eye scores when the eyes are damaged. The patient cannot open the eyes. The total score is usually meaningless. You have to give a breakdown of that, particularly the motor score affected by drugs such as drugs and alcohol. If the patient doesn't understand your language, there is a problem. In that case, you cannot use it. You can use it in an intubated patient, but you have to modify them both in intubated and children. Now, question number 9. 59-year-old type 2 diabetes present to the ICU post laparoscopic cholecystectomy. He was admitted to ICU for monitoring post-surgery due to significant comorbidities such as OSA with a AHI of 42, which is pretty high, history of triple vessel disease with history of congestive heart failure. He is on metformin, empagliflozin for his type 2 diabetes mellitus, which was continued till day of surgery. That's the crux of the question. So he came to ICU on high flow nasal oxygen with a FiO2 of 0.3, flow of 55, and was visibly in respiratory distress. His lungs sounded clear and the arterial blood gas showed the following, which is pH of 7.06, normalish PO2, PCO2 is pretty low, 21, bicarb is low, lactate is 2 only, and rest of the labs are fine apart from a little bit of raised potassium. His blood sugar were 98 milligram per deciliter, which is normal. Which of the following option best fitting to the diagnosis, right? So look at the question. So crux of the question, metformin, empagliflozin, right? Somebody with respiratory distress, but the lungs are clear. So it is probably a compensatory mechanism that is happening. The patient is breathing because of metabolic acidosis rather than anything per se in the lung. So what can it be? Type 2 diabetic who is on empagliflozin has a acidosis and breathing heavily. It is a acidosis or a ketoacidosis. Now the sugars are normal, so it is probably a euglycemic ketoacidosis caused by empagliflozin. This question can be twisted again. They can give you a high lactate, like lactate of 10, and rest of the values are normal with a low renal with a renal dysfunction. That can be a metformin toxicity also. So that can be changed. But in this case, gliflozin with a normalish lactate but acidotic. So high anion gap acidosis here, or acidemia. What are the cause for this? In presence of gliflozin, it is a euglycemic ketoacidosis. That's the answer. Okay. Most of the people have got it, 47.7. Now, the traditional ABG assessment, so I'm not going into detail. I believe people need to spend some time to learn how to assess ABG, and you cannot learn in a day. So it has to be a regular practice in your ward round. You need to look at the ABG every day in, day out, and try to go through the same sequence of things. I'll go quickly through that. First, to determine what sort of pathology it is, acidemia, alkalemia, then look at the PCO2, then decide what is causing it. So respiratory acidosis or alkalosis, then you have the differentials for that. And third thing, you look at the bicarb, then you calculate the anion gap, and then the gap ratio. There are various mnemonics to remember for the metabolic acidosis, high anion gap and normal anion gap. So this is freely available in all the free access in the internet. You calculate the compensation with the formula, and then if it is a mixed disorder, you calculate the gap ratio and look at what it is, right? In this case, what's happening is the patient has a pH of 7.06, bicarb of 14. He has metabolic acidosis. The anion gap is 23, which is high. The delta gap ratio is 1.1, which is a pure HAGMA or high anion gap acidosis. In this case, the lactate is normalish. So if you have an anion gap of 23 with a 2 of lactate, mostly it is a ketoacidosis. Okay, mostly I'm talking about. It can be alcohol and other things, but in this context, it is ketoacidosis, possibly euglycemic ketoacidosis. It is gliflozin induced. All right. Again, you need to see if it is a HAGMA, what are the differentials you have. Okay. Euglycemic ketoacidosis happens up to 3% of cases of DKA admission, particularly in the context of SGLT2 inhibitor, which increases the risk by 7-fold. Difference between euglycemic and diabetic ketoacidosis, the blood glucose level is usually less than 250 or even lesser in euglycemic. In diabetic, it is pretty high. Symptoms, mild or absent, usually not that sick, but DKA are heavily breathing and they are very sick. Insulin deficiency, actually in euglycemic ketoacidosis, if you look at, there is less of an insulin deficiency, but in DKA, there is more insulin deficiency. There is less of insulin resistance compared to DKA, and renal glucose clearance is very, very high because that's how the SGLT inhibitor work. And there is endogenous glucose production is high in DKA because the gliflozin suppresses the neoglucogenesis, but not in DKA. So the mechanism of action, how SGLT2 inhibitor works. So they cause glycosuria, they cause natriuresis, they cause increased ketone body reabsorption. So that's the mechanism how the ketones increases in the blood, right? They also cause decrease in insulin secretion and increase in glucagon secretion. The ratio between insulin and glucagon is decreased, or the glucagon value in the body, circulating glucagon in the body increases. That predisposes again to more ketone formation, right? Lipolysis increases lipolysis and then causes ketogenesis. So that's the mechanism. That's how SGLT2 inhibitor work. So increased glycosuria, increased natriuresis, increased ketone absorption, decrease insulin and increase glucagon, which indirectly causes more lipolysis and more ketogenesis. So that's why the ketone part of things increases. But the glucose remains the same because you have a compensatory glycosuria that is happening because of the drug. So these are the diagnostic finding in euglycemic decay. So very important question. So there is recommendation from various anesthetic society to stop the gliflozin depending on which guideline you're looking, 4 to 5 days prior to going for a major surgery. Question number 10. So 69-year-old presenting to ICU after being brought in by an ambulance. He was drowsy, difficult to rouse. He was lying on the floor at least for 18 hours before being found by his neighbor who called the ambulance. His blood investigation showed the following. Background history of diabetic nephropathy CKD3. He was well in the community and has never been on hemodialysis. His current vitals are height rate of 140, sinus tachycardia, as you can see. Blood pressure is 88/74. The important thing is the pulse pressure is very low, only 14 there. Saturating 88%, high flow 0.7 FiO2. He was peripherally cool, capillary refill is more than 8 seconds. Raised JBP, his arterial line trace showed the following, and on a focus echo, you found the following. So arterial line and focus echo. After initial resuscitation, what will be the next action? So it looks like there is a pulsus paradoxus, which is exaggerated with a low or a narrow pulse pressure, sinus tachycardia, and different height of ECG. As you can see, there is a variable height of ECG. And he is tachypneic with a raised JVP. So what is the diagnosis based on this? Pericardiac fluid, so it is pericardial effusion, possibly causing tamponade. That's his investigation. He is anemic, white cells are high, platelets are moderately low, creatinine is very high, urea is very, very high, sodium is very high, and potassium. So all fits into a renal failure. So if you put everything in this context, so patients who is uremic now presented with a pericardial effusion, so it is probably a uremic pericarditis. So what is the treatment? Treatment is urgent decompression plus decreasing the urea and doing a CRRT. So in that case, the C is the answer, urgent CRRT and pericardiocentesis because of the life-threatening potassium also. That's the first thing to do. All right. Now going into the answer. Okay, people said only pericardiocentesis. I mean, yes, that is part of the answer is correct, but I think both needs to be done because I think this patient will be killed by both raised potassium and the tamponade physiology both. So he needs a CRRT and also pericardiocentesis. They can ask you about echocardiographic sign of pericardial effusion or tamponade. What are they? So you'll have a separation of the pericardium from the posterior wall. Based on the size, how much it is separated, you can estimate the fluid. So every 10 millimeter is up to 100 ml, we say. 20 millimeter is 500, more than 20 is more than 500 ml. The size of the effusion does not necessarily predict the pericardial tamponade, but the rate of rise of the effusion, how much is accumulated in a short time, is predictive of the outcome. Common fallacies are you will have fat pad in the anterior wall usually, or pleural effusion can complicate the situation. So how do you differentiate? The separation of the descending thoracic aorta from the pericardial surface. If it is there, then that is a pericardial effusion, but if there is no separation, it is probably a pleural effusion. Now they look for also other features like diastolic right ventricular collapse, one of the important sign. Systolic right atrial collapse, again, there's another important sign. Then you look for mitral inflow. You'll have a plethoric vena cava, like a thick or a thick vena cava, and which will be, there will be less respiratory changes with it. So your different indices of IVC will be suggesting that the patient is full or the IVC is full. And there will be exaggerated respiratory cycle when you put a pulsar Doppler across the mitral, then the variation in mitral inflow will be more than 25%. So these are the important signs. At least you need to know the names of it. So which are separation of the pericardial sac, then diastolic right ventricular collapse, then systolic right atrial collapse, plethoric IVC, and variation of more than 25% in mitral inflow. These are the important signs that you look for. Treatment is ABCD approach, immediate, if it is a post-cardiac surgery, immediate chest reopening or pericardiocentesis. They are fond of asking this question. So what are the CVP changes you get in tamponade, and what are the CVP changes you get in constrictive pericarditis? Also tricuspid regurgitation and Canon A wave, where do you get it? So these are the 4 or 5 CVP TRICS question you can get in the exam, particularly in the OSCEs that you will get. So in cardiac tamponade, what happens with the CVPs? CVP is usually raised. All the CVP waveform components are elevated. All the waves are higher. A and V waves are tall. There is X descent is steep and Y descent is usually absent, right? That's for the tamponade. The Y descent is usually absent in tamponade because early diastolic blood flow from the right atrium to the right ventricle is impaired. This is the early diastolic is impaired by the compressive effect of the surrounding pericardial fluid. So you will get no Y descent or absent. But in a constrictive pericarditis, the pericardial constriction, the CVP will be raised, and X and Y descent both are steep like this. Okay. There is no Y descent here, only X descent present. That's the tamponade physiology. This is both X and Y descent are stiff, then it is a constrictive pericarditis, more chronic. 11, question number. So 50-year-old male admitted to ICU with aortic and mitral valve infective endocarditis. He has been consistently blood culture negative for last 1 week. So blood culture negative for 1 week. Is on adequate antibiotic therapy. His toe reported to have a severe mitral regurgitation and aortic regurgitation with mitral coronary cusp perforation, right? There is a 15 millimeter mobile vegetation attached to this cusp, and there is visible thickening of aortic valve also. He was hypoxic in pulmonary edema requiring emergent intubation. His current vitals are heart rate of 124, AF, blood pressure of 80/34, requiring 18 microgram per minute of NORAD, 12 microgram per minute of adrenaline. Saturation is 88% on FiO2 0.6. He is in controlled mode ventilation with a PEEP of 12. A recent CT abdomen showed multiple hepatic infarct and splenic infarct. There is no demonstrable embolus in the brain. What is the best next step managing this case? So answer is urgent cardiothoracic referral for consideration of urgent double valve replacement. So surgical treatment is the choice here because I'll go in detail about the recommendation. Most of the people have said that a more elective surgery should be considered when the patient is more stable and not in pulmonary edema. But the bottom line is that the pulmonary edema is because of the cardiac abnormality or valvular dysfunction, which is not going to get better unless it is fixed surgically. That is the bottom line of that. You cannot treat this patient medically with a, he's already on PEEP of 12, he's already on a FiO2 of 0.6, and there is a worsening trajectory. In this case, early fixation of the valve is indicated. We'll go to the guideline now. Let's look at that, what it say. Now, indication of surgery in infective endocarditis is very specific. Congestive heart failure. So if the patient has specific aortic regurgitation, severe aortic regurgitation, valve obstruction caused by the vegetation, severe acute aortic regurgitation with echocardiographic signs of elevated left ventricular end diastolic pressure or significant pulmonary hypertension, or if it is a prosthetic valve, there is prosthetic dehiscence of the obstruction. In this case, the patient has severe aortic regurgitation with congestive heart failure. Periannular extension, patient did not have it. That's another indication. Vegetation, if it is a recurrent vegetation, if it is a large vegetation, more than 10 millimeter. So this one is more than 10 already. So that's another indication for that. Or very large without embolic complications. The patient has large, very large vegetation and also has embolic complications, right? And doesn't have any brain seeding or brain emboli that reduces the chances of bleeding to the brain also. If there is a persistent sepsis, the fever persists or blood culture positivity persists, but the patient is blood culture negative, so he is probably is getting cleared, but he has mechanical complication of infective endocarditis. So these are the indication. Specifically, if there is a Staph aureus, then it is prudent to do a surgery. So these are the specific indication where you consider a early surgery in this patient. For this patient, surgery is the only way to get him better. Regarding intracranial pressure monitoring, ICP in TBI, which statement is false? Okay. ICP monitoring is indicated in patients with severe traumatic brain injury, GCS of 3 to 8 after resuscitation and as abnormal and an abnormal CT. ICP monitoring is indicated in patients with severe traumatic brain injury with normal CT if 2 or more of the following is present. If the patient is more than 40 years old or has bilateral motor posturing or his systolic blood pressure is less than 90 after resuscitation. These are the two correct answers. Multiple trials have shown mortality benefit with ICP guided therapy. This is wrong. None of the trials have shown any ICP mortality benefit with ICP guided therapy. Yes, the ICP control is better. Probably the length of stay is better, but hasn't shown any benefit with ICP targeted treatment. Rescue ICP trials showed decompressive cranectomy in patients with traumatic brain injury and refractory intracranial hypertension resulted in lower mortality and higher rate of vegetative state. That's correct. So the false statement is statement C. All right. Again, most of the people have done it. That's good. Intracranial pressure. So indication of ICP monitoring, very important. That's the Brain Trauma Foundation guideline. So you monitor the ICP if the patient has a GCS of 3 to 8 after resuscitation and there is an abnormal CT scan. If the CT scan is normal, but the patient is more than 40, have motor posturing or a systolic blood pressure of less than 90. Out of these three, any two are present, then he needs a ICP monitor, whether that is a Codman intraparenchymal or intraventricular, whatever modality. But if the CT scan is normal with a low GCS and two out of the three conditions are there, then they need a ICP monitor as per the Brain Trauma Foundation. They talked about two trials, rescue ICP or predominantly rescue ICP they talked about. So this is the most recent trial about decompressive cranectomy, where there are over 400 patients randomized to patients who have refractory ICP. And despite medical therapy, it is not controlled. So they looked at medical therapy versus cranectomy. And they found that the mortality is decreased, but the rate of vegetative state is increased. So almost 4 times the people are more disabled compared to patients who did not go for decompressive cranectomy. Okay. This is in the background of previous trial. That is the DECRA, which is a 155 patient trial. In this trial, they showed that there is decreased burden of intracranial hypertension, decreased stay in the ICU, worse outcome, extended Glasgow Coma scale in the survival at the 6 months. So this is the trial that leads to further multi-center extensive trial, the rescue ICP trial. They showed mortality benefit, but there is more survival with disability. They can ask you about what are the types of decompressive cranectomy. So decompressive cranectomy can be two types, primary and secondary. Primary is leaving the bone flap out after evacuating an intracranial mass lesion, such as a blood clot, extradural, subdural, or intracranial traumatic hematoma or contusion. In those cases, you go there, evacuate the blood, and leave the bone out. It's a primary decompressive cranectomy. Secondary is a tiered therapeutic protocol because of raised ICP, in this case, traumatic brain injury. Initially, the patient was not undergoing any surgery because there is nothing focal that can be relieved. But with the rising intracranial pressure, you want to decompress the brain by taking the bone flap off. That is called as a secondary decompressive cranectomy. Okay. I'm not going to this guideline. This is about the EDH, so don't bother about it. Question number 13, which of the following is false about prone positioning in management of ARDS? This is a bread and butter question. So answer is drainage of secretion becomes difficult. No, it becomes easy with prone positioning. Rest of the options are correct. We'll discuss about it. All of them, 41% people have said D is the correct answer. Now, they can ask you about what are the benefit of prone positioning compared to supine. So there are 5 or 6 benefit noted, right? First of all, if the patient is prone, it improves the VQ mismatch. The ventilation becomes more homogeneous. There is less of lung deformation. There is increased FRC. There is improved drainage of secretion, improved response to recruitment maneuver, and improved mechanics of the chest wall in obese patients. These are the 6 benefits that is there. Okay. In diagram, so what happens is you have a more uniform VQ ratio throughout the lung. Then the dependent part of the lung becomes non-dependent when you prone them. There will be uniformity in the compliance of the lung. There is improved movement of the diaphragm, so less lung is squashed. There is decreased pressure of the heart on the lung, so more lung is free to be expanded. And the FRC increases up to 300 to 400 ml. So these are the benefit of prone position ventilation. They can ask you about the trials. What are the trials in prone position ventilation? Recent trials, both intubated and extubated patients, COVID era, very important. At least you know the names of the trial and what is the outcome of those trials. Question number 14, 52-year-old smoker presented with acute onset chest pain and shortness of breath. On admission to emergency department, he was peripherally cold, diaphoretic. Vitals in ED following heart rate 140, sinus tachycardia, blood pressure is 84/44, received 1500 ml of crystalloid, but continued to be hypotensive. Immediate CT pulmonary angio showed the following: A bedside echocardiography showed a severely dilated RV and a D-shaped septum. His initial laboratory investigation, creatinine is raised, LFTs are raised, troponin is raised. He's currently on 10 microgram of noradrenaline. So he has been possibly adequately fluid resuscitated, and is now on quite a hefty dose of noradrenaline. Which of the following is correct about the management of P? So this patient has a P, and he has organ dysfunction in terms of LFTs are deranged. He has a high troponin. He has a renal dysfunction, and he's shocked in spite of being resuscitated. So that's a severe or high risk P. Okay, we'll go to the classification. The treatment choice in this case is thrombolysis and percutaneous catheter directed treatment, whichever is possible. So you need to take out the clot emergently. Most of the people have answered correctly. So as ICU clinician, you need to know about risk stratification of P. This is a bread and butter question for any ICU exam. So this is the new European Society of Cardiology, ESC guideline. So suspected P in patients with hemodynamic instability, bedside echo if possible, if there is a right ventricular dysfunction, CTPA if possible, available, and you can do it. Yes, there is a CTPA positive, then treatment as a high risk P. High risk P, these are the criteria for high risk P, which includes cardiac arrest, patients. So high risk P, it includes the cardiac arrest. If you have a high risk P with hemodynamic instability, reperfusion treatment or hemodynamic support is the important part. Then maintenance treatment with your therapeutic anticoagulation that can be done with the heparin or NOACs, depending on what sort of organ function the patient has and all those things. So for high risk P, you always aim for reperfusion treatment, and which includes systemic thrombolysis or surgical pulmonary embolectomy. For intermediate risk P, in that case, you need parenteral or oral anticoagulation, you need close monitoring, and if the patient deteriorates further, then you can do rescue therapy in terms of reperfusion, whether it is thrombolysis or catheter embolectomy. Low risk P, oral anticoagulant, and home discharge. So you need to know how to classify the P, which is high risk, low risk, and intermediate risk. Then again, high risk is classified in certain other classification as moderately severe and very severe. So depending on what you have, you tailor your treatment. Basically, if it is classifying as a high risk P, then thrombolysis or thrombectomy is the treatment of choice. Which of the following statement is false about vancomycin resistant enterococci, right? This is an important domain of the exam also. So you need to know a little bit about antimicrobial resistance pattern and what are the treatment choices for different type of resistance, okay? So Enterococcus faecalis infection is usually less severe compared to E. faecium. E. faecalis is more penicillin resistant and carbapenem resistant than E. faecium. Van A strains are resistant to ticoplanin, Van B strains are sensitive to ticoplanin. So one of them will be wrong for sure. But the answer is B here. So let's see. B, most of the people have correct answers. Now, difference between E. faecalis and E. faecium that you need to know actually. So E. faecalis are less severe. The mortality is around 10%, but it becomes 5 times more if the patient is infected with E. faecium. So faecalis ends with lis, so it is less lethal. That's how I remember. Lis for less lethal, okay? Faecium is more lethal. It is mostly associated with critical illness, nosocomial infection, cancer, patients who are neutropenic, renal failure, or risk factors for getting an infection. In those cases, faecium is more pronounced or more severe and causing higher mortality. Half of the patient die. E. faecalis is less penicillin resistant and carbapenem resistant. E. faecium is more penicillin and carbapenem resistant, right? Now, multiple vancomycin resistance type has been found from Van A to Van G, but most common is Van A and Van B. Depending on where you are practicing, there are different types of enterococci. Van A is resistant to vancomycin and ticoplanin. In that case, you cannot use ticoplanin. Van B is sensitive to ticoplanin. So for ticoplanin, you have to have VAN B. Options include teicoplanin, linezolid, daptomycin, quinapristine, and dalfopristin, tigecycline, or ceftaroline. Depending on where you're practicing, you can talk about what sort of antibiotic you want to use. And sometimes probiotics may be used in these cases. But the crux of the question is, which is more severe infections, so FECM, which is more resistant, FECM. What are the types of vancomycin resistance, VAN A and VAN B? VAN A is resistance to both vancomycin and teicoplanin. VAN B is sensitive to teicoplanin. So if you have a VAN A, you have to look for an alternative. A for alternative, that's how I remember. So VAN A, alternative treatment, not teicoplanin. So teicoplanin is the usual thing that we do if you see enterococci, right? Okay, that concludes my presentation for all the 15 questions. Hope that has helped. Few people were asking about what will be the course, how do you enroll? So that's a QR code for the course. You can scan it and register and pay for the course. And the important thing is the course is already started, but it doesn't mean that you cannot join, because you can have access to previous questions and the same pattern of mock test. You will get a link, you'll get an analysis of your performance. So you can have that access of that mock test anytime you join into the course. You'll have access to all the study material, all the videos. So nothing is less if you are joining later on. But to be time bound, that's why we have kept it before the exam, so that we can finish up all the modules, all the 10 modules and mock test in time. That concludes my presentation. If you have any other questions, I'm happy to answer. Tapas, if you are still on. I can see a thumbs up there though. All right. If you guys don't have any other questions, then I'll probably sign off. You should have got your answer sheets in your email, which you can go through later on. And if you have any other questions, just let us know. We are happy to help you. There is a question somewhere. Till what date we can join the course? So there's no fixed date. You can join anytime. But as I said, it is a time bound. We're looking at the exam dates, and then we put it like that so that it finishes a little bit ahead of the exam, and so that you'll have time to revise and do things around it. Okay. Anonymous attendees has addictive preparatory course. It's coming. So we are waiting for this class to happen, and you will get a flyer probably tomorrow or day after. You'll get a flyer there. Any other questions? Where we can find? What do you mean by where you can find? Oh, the flyer. It will be in your WhatsApp group. So stay in this group. You'll get the flyer. We'll share you the flyer. So if you can share us the contact, you have the contact number from us. So you can share your contact and we'll send you the registration link. So we are this time there's a new pattern of the whole course, and there are more practice tests are uploaded. We are no longer 10 module, it will be 12 modules this time, and you have more access to more number of mock tests. So probably you will get, previously it was like 2 CCS in the addictive exam. You'll be getting 3 or 4 CCS each chapter this time, but we'll have limited candidates. So if you want to enroll, you need to be a bit on your toes to get it early. Any other questions there? Otherwise, I'll log off. All right. Thank you all for your patient listening, and let us know if we can help. Even if you don't enroll the course, that doesn't matter, but we are happy to help. You can text us. There is a phone number in the website and the contacts of all the flyers. If you have any questions about the exam pattern, what to read, where to read, we're happy to help out. Thank you for your participation, and good night. Thank you. Website is 360criticalcare.com. That's the website. All right. Thank you then. All right. Logging off. Thank you.